Awesome. Well, welcome everyone to iCode Media Podcast. Chris and I are joined by two rock stars. I have been looking forward to this discussion for weeks since the inception of the idea, and so what we want to talk about today is visual fields, something that I don't think I've dove into since optometry school. I think the last time that we had like a let's talk about visual fields was optometry school, maybe once or twice with some of the interns we get. But we're going to hit that, and hopefully in a fun way. But before we do, I want to introduce the panel. You all know Chris Wolf, and he's joining.
Thanks, Aaron.
Absolutely. And then we've got Shane Kennar and Gina Wesley. So Gina, let's start with you real quick, where you are and what you do.
Yeah, well, thanks for having me on, first and foremost. And I practice outside of Minneapolis in the western suburbs, Medina. I have a single location practice. I have another doctor who works for me, and we specialize in a lot of dry eye, myopia management, and I do a lot of clinical research and studies and some consulting and speaking in the industry. So it's I've never spoken on visual fields, so this is a first for me. I feel like that's part of why you maybe had me on. So hopefully, I think this will be an interesting conversation because it's a very important one, I think.
Yep, absolutely. And Shane?
Shane Kennar, I practice in Pittsburgh, Kansas. I always say the real Pittsburgh. We're about an hour and a half south of Kansas City, kind of tucked in the corner of the state. A rural setting, 5 doctors in the group now that I work with. Also do a lot of clinical research and involved both speaking and consulting as well. And
Aaron,
yeah,
go ahead.
Go ahead.
Go ahead.
No, visual fields is an underrated topic, I think.
Yeah, I think, Aaron, that's kind of what was exciting to me when you and I were discussing this episode is, visual fields seem sort of rudimentary. It's like, well, what's the next big piece of cool equipment that I could purchase that's going to be revolutionary? And yet we still have this device that tells us so much information about what disease processes are going on. And when you look at the metrics, the KPI data within CMS build data, you just think, and by the way, there's so many conditions that guidelines and practice patterns tell us we ought to be using visual fields for, that to see that we are not using visual fields at any significant amount makes you wonder, like, why is that? Is there just this fundamental misunderstanding about when we should order a visual field? Or is it reliability? Or is it convenience? Or is it, like, what are these things that make us not do that as a profession? And so that's kind of what excites me about it, and excites me about having both Shane and Gina here, because they're in clinical practice, right? They think like optometrists. They think like high-level optometrists who perform studies, but they also think like optometrists. And so kind of trying to tease those ideas out about why it is the case that we do, that we know what we ought to be doing, but then we deviate it from it. I kind of want to tease some of those things out. So thanks for bringing this up, Aaron. I think it's going to be great.
Absolutely. And to build on that a little bit more, and Chris, you did a really good deep dive a year ago into visual fields and CMS data. You actually did a podcast. We'll link that in the notes. The title, I believe, was what the data tells us about us. And it wasn't the best story that we want to hear. But it's what it is. And prior to that, you and I had gone down a journey of looking at medical KPIs. You and Kyle do a lot in COS, Comprehensive Optometry Simplified. And I'll be honest, when we started looking at the data, I was surprised that in my office at how less visual fields I was doing than I thought I was. And we looked at it, and we part of the reason that I think we were struggling was, one, it's a test that nobody loves. Right? I've never had a patient come in and go, I want to do that test. I've had them come in interested to see other things. Optos and OCTs are exciting, and you can dive in. Visual field was shove your head in a giant box and stare straight at the light, don't look at anything else, and push the button. It was a really bad video game. Staff hated running it, and it was hard to find time to schedule. We're working 2 doctors out of 1,800 square feet, so there was some challenges in when to schedule, when to push it. So it was really easy to say, we'll do it next time. And tomorrow never comes, right? It was really easy for us to do next time. And or if we did get somebody into the Humphrey, it was, they weren't comfortable. It was hard to get a good result out of it. And so it felt like a lot of failures. And then interpreting the test, it was easier to go to something that I can see a color picture of. Not to say that I didn't find value in it. It felt easier to walk through that in front of patients. So I'm curious, for the three of you, hopefully you were all more successful than I was. And when I started looking at the numbers, but is that something that you guys came across, your teams came across?
I think all those points are very valid, and we just using some of your KPIs at a doctor meeting, and of the 5 practitioners, we ranged from 1% visual fields to 13%. So very diverse, and nobody really knocking it out of the park. And I think the other thing that comes with that, as we discussed it, is, was I getting good test information and good reliability? And when you get in some of the older devices, I always say the best way to make a field better is do it again. There's a learning curve. And now I think we're seeing this modernization of visual fields, where we do have less of a cumbersome experience in our office and more repeatability. And so we can really start to fall back on that. And I think Chris brought up a really good point. We think of visual fields in glaucoma. If you survey the average OD, that's where you're at. And there are so many other reasons we should be doing them in our office.
Well, Shane, you had your team, because you sent me an email, you had your team go look up all the ICD-10 codes that are appropriate to run a field on.
Yeah. Do you remember the number?
It was over 2,000.
2,700 codes.
Wow.
So Shane, I want to clarify something. If you're a first-time listener to kind of the idea of what Shane is talking about with 1% or 13%, one of the KPIs that we talk about within iCode that Aaron was referencing is using the denominator of your refractions. So that tells us how large of a pool you likely are seeing over a period of time of patients who are being seen in the office, because typically somebody will come in and for a comprehensive exam, and there will be a comprehensive exam with a refraction. So the refraction gives us a denominator of how many patients we're seeing, and then the numerator in this case would be visual fields. So you'd want to know how many visual fields am I running per refraction. And then you can use kind of the data to tease out, prevalence data on glaucoma or the other 2,000 ICD-10 codes that you might be encountering with patients who have those conditions in your practice. Now you start thinking like, it should almost be, when you say that, Shane, it should almost be a 1-to-1 ratio, right?
Yeah.
Which is pretty staggering. And I haven't thought about it like that.
I think you're exactly right. And I just want to clarify too, when I look at visual fields, it's because I want real data. I'm not going to do it because the code supports it. But we routinely see working with primary care, and I think part of that's being in a rural setting, but we get so many referrals for headaches or a variety of conditions where a visual field really starts to give us a big part of the picture that we're missing if we don't have it.
Yeah, totally agree.
So I'm curious because my challenge was flow, right? So when I see something, I want to order visual fields, right? And we struggled with when we're going to do them, how we're going to do them, and the flow of it. Before I share what we ended up on for our office, how do you guys approach that in what you do? If you see something, do you order it that same day? Do you bring it back? How do you get that field once you order it because you know you need it?
In my practice, I started cold about 16 years ago, and I used to bring in a mobile unit, right? Like mobile testing, because I didn't have the capability to start doing, afford a visual fields or an OCT. And so that made us schedule, testing clumped together because there's only certain days that they would be coming to deliver those services to us. So it was very busy days. But then obviously as my practice grew larger and I was able to afford the technology, we are generally scheduling patients once we, are seeing a need for them. We have them come back, right? Because of the time that the visual field takes. And in the past, the room space, right? You have to schedule the room and the availability. So it was a little harder to do on the fly when we had a more traditional visual field unit that was sitting there on a tabletop that you had locked into a corner into a very dark room, right? That was hopefully being utilized for some other things. But obviously now that we have the Radius headset, that gives us a lot more flexibility, which has increased the number of visual fields we've been running. But I still think we could be doing a lot better, for sure.
We're in this kind of transition phase in our practice, and there's a lot of patients who need eye care, and we're trying to figure out the way to best make use of the doctor's time. And it is really a scheduling nightmare if you're bringing a patient in for a field and an OCT, and they're on the doctor's schedule, and is that going to run appropriately? And it has gotten better. Integrating Radius and Tempo and some of those newer technologies lets us run a little more on time, but it's difficult. And in this last year, we've made a transition where when patients are going to need robust testing, and I think it comes from a discussion with you, Aaron, but I'm not sure, we'll schedule patients and I'll say, I'm going to see you in 4 months to check your pressure. In the interim, we're going to bring you back and do these tests, and I'm going to go over them with you at your visit. And that does a couple things. One, it increases our efficiency, but I really find that I'm doing better poring over the data, because now I'm not knowing the patient's up in 2 minutes and I'm behind. I've got that 2 weeks early. I sit down and I do a block of them. I dictate the notes I want, and I can really spend a little bit more time analyzing the testing I see.
Shane, when you talk about that, can you tell me, 'cause I know that there's listeners that are going to be thinking about, so wait a minute, you're already having the patient back 3 times a year for their glaucoma or twice a year for their glaucoma, and you want them to come back another time for a separate test. Does that go through your mind? And if it does, or if it did, how did you, like, what was the framework of how you got over that concern? Or if that didn't, how could you help another doctor who is concerned about, can't let go of their cognitive anchor of, I'm only going to see the patient back 1 time a year, and I'll do everything I can possibly do so they don't have to come back more than once a year? How do you get beyond that?
So the answer is it was a concern. And in my mind, it becomes, when I go to my primary care doctor for a physical, I always text him because I want my labs done and everything so we can do it in one visit when I go in. And I still do, I give patients the choice. I say, I can bring you back, and it's probably twice a year on a glaucoma patient, and I can bring you back and you're not going to see me. I can do these tests. We can get you in and out, and your appointment's going to be more on schedule. Or I can bring you back and we can do it all. I just want you to know there's going to be some weight involved on your part, and I'll do my best to minimize that, but it's going to happen, because to get all these tests done, it's kind of a difficult situation. Which would you prefer? And the overwhelming majority are like, we'll be in, we'll get it done in advance, and we work really hard to keep that schedule flowing right on time.
That's probably more predictable. That schedule, our special testing schedule is way more predictable. Like, if depending on what visual field device you use, you can say, look, max time I'm going to need for this patient is 3 minutes an eye, and then I'm going to, for the visual field, then I'm going to do the OCT max time 5 minutes, right? Let's say 5 minutes or so. I can block out 15 minutes of time, and I will like dominate that space. As long as we don't get other people that kind of shift it because they're late or whatever.
Yep. Yeah, and say in that case, block out 20, because you're still utilizing space, and you make sure you flow on time. You got a little wiggle room, and there's really a fatigue factor with visual fields. And so I think when you do that, you're eliminating some of that fatigue factor as well.
We will have patients back, Shane, and Gina, I'd like to hear your response to this as well. But that's the exception. Like, to just do a special testing in our practice, we will do that, but it's the exception and not the rule. But you could convince me very easily that all our special testing should be done on days that I'm not there, or where the other doctor is there. We're like, because I start thinking about how efficient I can be. Pretty awesome.
Well, just real quick, the one thing I'll say is it's part of our mindset shift of going from information gatherers to assimilating that information. And I think that's a lot of the burden you're hearing is we feel like we have to be there together every piece of data. Sorry to talk over you, Gina.
No, I was going to say, I think some of that is born out of necessity. So when my practice was younger, And I've only ever seen patients 2 to maybe 3 days a week. I used to have 2 non-doctor days where I'd be home with my little children at that time. And we'd be like, well, why don't we have those patients when I finally had the equipment come in and do those tests? And either I'm calling them and foregoing the office visit for that consultation portion to do that, or having them back for an office visit for those who wanted to see me in person and, do everything. But it gave people the option, to your point, Shane, but it was also of necessity, because I was like, my days that I see patients, I'm so busy already with the scheduled comp exams and everything else. This was a way to get more visits into my office without me physically having to be there and continue to grow the practice. And so it should be embraced. And guess what? When you schedule like that, you actually find that you start to schedule more people because it's not going to be an interrupter to your schedule. I think we all know visual field testing is very important, but it is one of those tests that sometimes does go by the wayside. It's maybe not as glamorous as some of the other things that are out there. And I mean, let's be honest, it is nice to do a test when you see red, yellow, green and help you to quickly disseminate those results. And visual fields, I think they require a little more interpretation. And when you actually look at the published articles that are out there, some of the most read articles within our profession are the articles that go over how to interpret a visual field. Because clearly we learned this in school, but it can be complicated. And to really dive deep, sometimes you're like, gosh, I really probably need a refresher on this. Not always the most common continuing education content that's out there, right? Chris, I feel like I've heard you talk about this a few times, and I always learn every time, which is amazing. But
Thanks.
I think we have to recognize that if we can figure out ways to make this a more common thing in our practice, so that we're not shying away from it because of schedule, constraints, everybody wins, because we're getting more efficient data on the patient that will help us with them and their diagnosis. You're helping with your practice and billing and coding. I think creative thinking is a necessity when it comes to this.
One of the things, Gina, sorry to jump in, Aaron, but one of the things that it strikes me is that, by doing more fields, we get more comfortable doing more fields. It's the same thing I talk about with gonioscopy all the time. It's like the only way to get comfortable doing gonioscopy is to do more gonioscopy. And by the way, you get paid to do it, right? Like, there's not many professions that get paid to refine their skills, right? And by doing it. The other thing is, I do not want to rely on a visual field, the first time a patient does a visual field when it's when my butt's on the line, right? I want to know that patient has done 10 fields before or 15 fields before, because now they're a better test taker. And the data over time can be a lot more valuable than I finally did a visual field because their OCT changed. Now it's giving you data that's just not as reliable because the patient's not as reliable. But you'll find, and I bet you guys see this too, the more you do them, is that when you do more fields, the patient becomes used to it. They don't bark at it as much, especially if you use new technology that's comfortable and easy to do. And they're not as uncertain about what the test tells them, and you're not as uncertain about what the test tells you.
That's a very true statement.
Absolutely. And I wanted to pull those two pieces together, because what we found in our office is that scheduling bottleneck, and it created a contention between the techs and the doctors and what I wanted, and patients were stuck in the middle. And so we actually created on our scheduler a tech schedule. So patients will schedule with the techs just like they schedule with the doctors. So now they control that schedule. It becomes way more flexible for patients to come in. And like you, Shane, we gave them the option, but 90% of ours have chosen to come in on their own time. A quick, I'm going to go in and out in 20 minutes is a whole lot easier than I'm maybe going to be there for an hour. And we let them know, hey, we'll review the test and then we'll see you back. To not just give away our services, Gina, because we were like, I'll just call you, right? Telehealth is huge. Hey, and we tell them ahead of time, look, everything seems to be going good. I don't suspect there's a problem. So if everything's that way, we'll just set up a quick telehealth visit. And that way we can review the images with you, answer any questions you have, and then you can do it from the comfort of wherever, right? We'll bill your insurance in the same way and go from there. And they've been we could probably use that more, but the ones that have taken us up on it have been appreciative of that because they just want to know, is everything good? They tend to be the more established glaucoma patients. The biggest challenge that we had was, how do I document this? Right? Because if they come in on a Tuesday and I don't see them on a Friday, that falls outside the I do everything all in one visit mode that we were taught in schools. And so when I presented this, I've had that question frequently, and Chris helped walk us through that, but it's as simple as documenting the test results and interpretation in one chart, billing for the test interpretation results, and then opening a second chart the day they're coming in. You can reference them, but I don't need to bill for that test anymore. I can bill for the visit. So I'm still getting the same amount of value. It's in two charts, and quite frankly, it's pretty easy to document now with the EHRs and the EMRs.
It also strikes me, sorry, Aaron, but it also strikes me that separating them on separate days like that will probably make you less likely to forget billing it. I mean, I think there's probably opportunities to miss billing it if you don't have a process in place. But often, what I think a lot of optometrists will do is that, and this is surprising to a lot of other professions, but it's true. It's like, oh, I billed these two things, and then I forgot. Like, I forgot to bill this extra thing. I mean, I think you heard it in our discussion. Like, yeah, well, I do them, but I don't bill them that often, right? And it's like, okay, well, that's a problem. That's a big problem.
You're leaving money on the table, especially because visual field is not a low reimbursed test.
Yeah.
Right. It's paying more than your Optos or your OCT, and it also gives me the chance. What I found is it gives me the chance, if I see something that's odd, I don't have to figure out how to save face in front of the patient when I'm looking at it for the first time. And when we do it with the patient, often I'd walk in the room. That's the first time I'm looking at their results.
Oh, yeah. I never look at a field in front of a patient for the first time. Never.
Well, no. Right. And so this gives me a chance to look at it. And if there's something odd, I can figure it out before I walk in. And then when I walk into the patient, when I see them that second day, is, hey, I've looked over your results. There's one or two things that concern me. I'm going to review it with you now. Or I looked at your results. Everything's great. Let's just look at it real quick together, because they just want to know, am I good or am I not good? Where am I at? And that hemming and hawing in front of them is awkward for both of us. So I did want to, since we're talking about, Gina, you brought up a great point on how one of the most reviewed articles seems to be, how do I interpret a test? Right? And we've got three experts here. I would like to throw up just a couple of examples of a field and, walk us through how you look at this. And because I would love to hear how you interpret it, and also how you explain it to a patient. So
Aaron, can I add, when you think about interpretation, Gina and Shane, one of the things I want to add is obviously, like, interpret it like you're teaching, an optometrist, but then also I want to hear, I think it would be really helpful, like, interpret it as it's going to be documented in the chart. If you can do that verbally, and Shane, I'm sure you can since you're dictating, I think that'll be really helpful to the listeners, because again, like, how do you articulate uncertainty? Is uncertainty okay? And with visual fields, uncertainty will exist. So how do you document that without? Because I think that's the other concern that a lot of people have is like, well, if I document this uncertainty, and something goes wrong, then what? And so maybe help us through that, Gina and Shane.
All right, can you guys see this here?
Mm-hmm.
All
yep.
right.
Cool.
Cool.
Can you go a little bit bigger? Can you actually blow it up and maybe full screen?
See if I can go bigger. If I go full screen, I'll just lose you guys, but that's fine.
Oh, you will? Then don't lose us.
Well, let's see if I can do this. Oh, there we go.
There you go.
That's
great.
Better. So, this is, you get this test, right? And we've got a right eye, 24-2 threshold, the by far the most standard test that we do. 26-year-old, we've taken all the patient's name out. But Shane, when you're looking at this, what's the first thing you jump to?
So the very first thing I'm going to look at is false positive, false negative. Do I have a field that's really worth me looking at? It's spending much more time. And, this case is very good. I'm sure we all have different thresholds. I know you'll see articles that say 30%. I'm a big 20%er.
I'm lower too, Shane.
I think that's big. And then I'm also going to look at mean deviation. That's one of the first things. Is it greater than -2? And if I see that, I'm really going to start to pay attention. Gina, where
Well,
would you
so
start?
Shane, pause there. So you're going to start the mean deviation is greater than -2. You're going to start to pay attention for what?
So I'm really going to look for more advanced disease. Am I seeing conditions that are starting to maybe have impact on the patient? Am I seeing areas of vision? I don't want to say testing error, but at I think -2, I know that there's something impacting the anatomy if I have a good field.
Cool. Now let me ask you this, Shane. If 20%, and I agree that's my threshold as well, if it's beyond that, do you throw it away or do you still look at it, but you look at it with an asterisk saying that there may still be some data here. You know you're gonna redo the test, but are you throwing all of it out, or are you still going to look to see if there's anything on it?
No, I'm not going to throw it out. How often should fields be done is a great discussion.
Lots.
Twice a year's a good number, but the first year I may do 5 fields. And if this is my first field with this patient, I'm not going to throw it out. Now, as I get more fields and can really start to look for more commonality, I may start to disregard it, right? I may start to kick it out then, but right now I'm going to have to use this as kind of a starting point.
Yep. So, and I like that 5 number the first year too. I tell patients, hey, we're going to do this. There's a learning curve to it. I need to get a bunch of data. So we're going to be friends. You're going to get really familiar with this test at the front end of it, and then as we get more comfortable, we'll settle into a cadence.
And for the listeners, sorry, Shane, but for the listeners that are thinking 5 fields in the first year, the European Glaucoma Society recommends, and I think even the American Academy of Ophthalmology recommends 3 to 6 fields within the first 2 years of diagnosis to establish progression rate. And then anytime we have a change, we're looking for that change consistently 3 times, right? So before we make a decision, 3 times. So again, and then you take a step back from that and you think, well, that's a lot. And when you think about that, then we don't have to worry about reliability as much or making a decision when one test isn't very good. It's really comforting. It's like, yeah, this wasn't very reliable. Let's do it again. Wasn't reliable. Let's do it again. Oh, it's reliable. Okay, now I can think about that. And then the other uncertainty I think that has people have it listening right now, Shane, is can you really bill it 5 times a year? What's the diagnosis code you're going to use? Because I want to eliminate these uncertainties for people.
So in my case, yes, I would bill it 5 times a year, but I would make sure and document this field shows false positive errors of 40%, unreliable field, unable to ascertain severity of patient's condition, repeat field for reliability.
So I love that wording that you've already put in the chart to articulate the uncertainty, to tell the story as Aaron likes to describe, to tell the story of your clinical uncertainty in managing the patient. And you articulate the uncertainty by good documentation.
Yep. I just for everybody who said, can you say that again, Shane? Because that's not what I document. Can you say that again, Shane?
Probably not exactly like that, but I would say, unreliable field, false positive errors greater than 30%, unable to document severity of patient's condition, repeat field for reliability and consistency, something of that nature.
Perfect. And I love that because it's simple, right? You said your interpretation. There's a high false for error, so it's not a good test. And what you can't do with it, but what you are planning to do going forward, right? So you're writing what you would say to anybody else.
And I do think one thing that I've heard either in a lecture or for some, don't just say it's unreliable, say it's why it's unreliable, and that's going to support you much more if there is an audit.
Well, that's the interpretation and report part, right? It's unreliable because.
Yep.
Yep. And Gina,
and
I think
it's
you were the one.
consistent with, so like this
Consistent
is,
with.
Consistent with glaucoma suspect, progressing glaucoma, unstable advanced glaucoma, something like that is also helpful, I think.
Yep.
If you
I was gonna
can
say,
make
Gina,
a determination. Sorry, go ahead.
No, that's okay. I was going to say, Gina, I think you were the one that years ago I stole from when you, in a talk, when you said one of the ways you like to talk to patients is using the word because. Right? So when you talk to a patient and you say, I want to do this because, right? You're having problems because or we're going to treat you with this because. And so I've learned to take that into my documentation as well, in interpretation, right? This is unreliable because, and it just makes it really easy to follow that story.
No, absolutely. And I think when I'm looking, especially the first couple of fields that people do, I know there's a learning curve, but I also don't put it all at the patient too, right? So I'm looking not only at the false negative and false positives, but I look at the fixation losses, right? There's a high number of fixation losses, regardless of false positive, false negative. I'm like, okay, tell me about this. How did that feel when you took the visual field? Well, it was really hard to concentrate. It was sitting kind of low. I was very uncomfortable, right? So I try to make notes about like, okay, next time we need to adjust the headset to be like this or like that. Or I don't know if you guys have noticed this too. If you always test right eye first and left eye second, there's a real fatigue component. And there are a lot of patients I have that we switch which eye is being tested first. Especially for these older patients, it is wild to me how often, no matter what eye I test first, the first eye usually has better reliability than the second. And it's not all patients, but there are a handful where we have to make these notes to switch back and forth. So that's kind of a tip that I always like to kind of get the story from the patient, right? To be like, well, how was that? Nobody ever says I love it, but like it was fine, or I was really tired today, or oh my gosh, I have so many floaters, it's really hard to see. Like you need to understand, because this is so subjective. And I tell patients that I say, look, right? Like when we're talking through the disease process and I tell them, we see this and we're going to test you because, to Aaron's point, I'm seeing that you have some thinner findings on your GCC scans. So because of that, we need to understand if that's actually translating to a loss of your peripheral vision. And my staff and everybody laughs at me, but I use a lot of hand motions, right? So for people who are listening to this podcast, because remember, what's the statistics? People only remember like a very small percentage of what you say, but they remember more of like motions and like feelings and how you feel.
Yep.
So I'm trying to make them feel the importance. So when I say, let's say it's somebody who's glaucoma, because it is one of the more common reasons why we're doing a visual field, I say, okay, you have a thinner retina. And I go, that part on the back of your eye is what makes us see. And I go, you can only lose so much of it before you start to lose your peripheral vision. And I literally am waving my hands to the side because people might not understand what peripheral means. And sometimes they say it's your outside vision, right? And so I say, we're going to bring you back. We're going to run these tests. I go, I need to know a bit more about the structure of your eye, but I also need to know how you're seeing, and this is going to be your job. This is your job. I go, you just have to look and follow directions for everything else. But I go, this one, you really need to pay attention. So I know, and we both know and understand how well it is you are actually seeing, right? Then I think people get really worried, and I'll say, sometimes it might feel like it's hard to see. Sometimes it might be easier to see. That's okay. That's the nature of the test. I go, and people think that the test is very static, that it's the same test every single time. And I say, you have to understand the test adjusts to you. So it gives you another chance, right? If you missed a spot or you didn't see it as well, it's going to give you another opportunity. Because some people get like a high level of anxiety during this testing to be like, am I doing okay? How did I do? This is my performance. And so giving kind of reassuring information like that to let them know, like, it's important, but don't panic. It's okay. We're going to get through this. And then again, the more you do the test, the more comfortable they get, the more reliable the data. Everybody wins.
Yeah.
I also find it's helpful to just even encourage them to say, like, listen, I know if this is a bad test or not a bad test. And so even though we want you to do as well as you can, I'm not going to make a decision based on one bad test. And that's why we repeat the test over time. And it's almost like sometimes on some of those patients, you could just see sort of this like, oh, okay, I can't really mess up my care because I do a bad job on this test.
Yep.
I tell a lot of patients before their test, we're wanting to look at your peripheral vision, and we're going to introduce a stimulus, and I'll either say a white light or a wavy line, depending. And we're going to keep bringing that up until the level that you can see it. So I don't need you to search for it. I need you to stay on where you're supposed to look. No, we're going to get there. We're going to hit the spots. We're just gradually increasing it to see what level you'll notice it. And that kind of gives them this, hey, I don't have to catch everything. We're going to see it over. And I think it helps. I've got to say the headset, the Radius has really helped. I think because of some of the postural issues that go on. And I also think just the quicker test helps our staff be more checked in as well as the patient. You're not in a dark room for 30 minutes waiting to get this field done. Those things have helped us get more reliable fields for sure.
I'm actually curious, you guys, how you explain the results. I want to hear what you say to patients with explaining and interpreting this field when you're showing this to the patient.
The Myopia Collective. CooperVision and the AOA have partnered in a groundbreaking initiative to change the way optometrists in the U.S. treat children with myopia. The purpose of the Myopia Collective is to rally the profession of optometry and its allies to interrupt the status quo and elevate the new standard of care for children with myopia. Every individual is encouraged to become a member of the collective. By joining, you commit to taking action to help slow the progression of myopia in children. You'll receive updates and information about the collective and its work in the fight against myopia, gain access to educational opportunities and resources offered by the collective, and hear from change agents, the ambassador optometrists selected to serve as advocates for community and policy change that facilitates the mission of the collective. Scan the QR code or click on the link in the show notes to join the collective today. In the past, our focus revolved around prescribing MacuHealth or MacuHealth Plus to patients at risk of macular degeneration, while also recommending it to collegiate and professional athletes for enhanced contrast sensitivity in sports performance. However, this year's introduction of the Life Meter has been a game changer. The Life Meter revealed a concerning truth. Many of my patients have alarmingly low skin carotenoid levels, indicating potential deficiencies in essential body tissues like the retina and brain. Supported by over 30 peer-reviewed publications, Life Meter's accuracy, consistency, and effectiveness has been demonstrated across 2,000 subjects with diverse backgrounds. With this newfound insight, I can now have meaningful conversations about carotenoid levels with all of my patients, even those who may seem outwardly healthy. To learn more about this empowering technology, feel free to contact your MacuHealth representative or click on the link in the show notes. Together, let's optimize patient care and elevate their well-being. I think for me, that's really the only time the grayscale chart area comes in big time, because that's their visual representation that I think they can see. And I tell them that it's a pseudo image of them looking through a pair of glasses, but as their eyes. And so I show them the blind spot first. We play the little thumb game, and I explain the quick anatomy of how that's where the optic nerve leaves your eye. And so it also is where we test during the test, which is why sometimes you didn't see a light, right? Because we were flashing in there and checking to make sure you were right. And then the areas that are a little bit darker are where the light had to be brighter for you to see. And so straight ahead, it should be super bright. It can be dim. In the periphery, it might need to be a little bit more brighter. But then we want to make sure that we maintain that as you go. And by this point, they're interested, but they kind of look at the numbers and are overwhelmed. And I say, well, it's my job to look at the rest of the data on this sheet to let you know whether we're stable or progressive. And by looking at all of them and historically, you're stable, which means you're doing the right thing, so keep doing it. Or I'm starting to see some changes, so we need to make whatever adjustments we need. Shane, Chris, do you guys do anything differently?
Gina doesn't get to ask the questions. This is not her podcast. So Gina, I would say, in this one, it's kind of boring. I'm happy to do another, but this, what I would say in this case, Gina, is I would say, hey, Gina, as we've talked about, your risk for glaucoma can impact the side of your vision. I wouldn't do that. That's yours. And it can impact the side of your vision. And so this test allows us to see the extent of any potential vision loss that is outside of the central part of your vision. And so in this case, the great news is that that we're watching you, and at this point you have no vision loss because of, and exactly what Aaron said, because when we look at this image here, and I would show them that grayscale, that dark spot, which is supposed to be there, is one of the factors that tells me if this is a reliable test. And then any other big black spots outside of that would show me areas you can't see very well. And according to this test, you're seeing really well in all those other areas. And that's pretty much how I would articulate it. Now, if I had another one that did have a defect, then I would correlate that, like that paracentral defect that we're seeing here. I can't see the other pattern standard deviation, Aaron, just yet, but I'm assuming that based on the grayscale, it's a paracentral defect on the image you're showing right now. A superior paracentral. Yeah. Can you scroll up a little bit more? Yeah. Okay. So then I would if I saw that, then I would say, Mrs. Wesley, that area that you're seeing right here above the center part of your vision, or the area you're not seeing right there above the center part of your vision, also corresponds to this area on this scan of your retina that is not dependent on you and your response, but shows me areas of thinning in that nerve fiber layer. And that's very consistent with the development of early glaucoma. And if I were geeking out and I were going to be a Shane Kennard, I'd say I likely think this patient has normal tension glaucoma based on that type of visual field defect. But Shane, I'll let you kind of take it from there.
No, I think you hit it on the head. And I think when I'm talking to this patient, I'll bring up, hey, that may not be an absolute blind spot, but we know above fixation, you need more contrast to be able to see it. My job now is to intervene with your care and keep that from progressing. I want to look at a field like this for the next 30 years and tell you it looks exactly the same. And I do think it brings it home to patients. I think it brings it home a lot. And we've talked about glaucoma here a lot. I really like doing fields on my moderate macular degeneration patients, because when I can tell them, okay, and I come back to the grayscale for this, see these islands where you don't have vision? So when you're talking to me about trying to look at the TV and you can't see anyone's faces, this is why. But I think not only does that help me clinically see if that's getting deeper or progressing in size, it helps the patient understand what the disease is doing to them.
Shane, that's such an important point that I think we as a profession don't acknowledge the value of these tests as often as we ought to. Is that exact point you just made, is that I always like to take a step back, and I'll be the first one to say, I want to look at, when I order a test, how is it going to change my treatment? I don't want to order tests that don't have the potential to change my treatment. But what you've just articulated is exactly another reason why we might order a test. Like, I know you don't have wet macular degeneration, and I know you don't have geographic atrophy, but I don't know how I might communicate differently to you with your macular degeneration related to the types of things that you might encounter in your daily activities, your quality of life. But now if I do that test, if I run a 10-2 on you, I might know more, and I can have a better conversation, and I can add value to my patient's life, and maybe even protect them from falls or other obstacles in their journey. And that's valuable. Right? That's really valuable to the patient, and it's really valuable to the healthcare system, and we have to remember that.
You bring up a great point, Chris, because this is a conversation I also have too with my patients that are older, and let's say they're accompanied by a family member, and a lot of this is very obscure, right? Like it's really, not, people don't necessarily understand what it is we're testing and what we're doing. They may have like the vaguest, idea, but I'll say to patients, and I think that, to our credit, with the technology we have in place now, we catch a lot of our patients. I mean, less the macular degeneration patients, but we catch a lot of people before they have noticeable field defects. And there really is a value in educating them, because they can become complacent, right? Like if everything is well controlled and maybe they have a small inferior quadrant defect that they don't notice in their day-to-day vision. And they're like, I've been doing this for years. I'm tired of doing this. Why does this matter? I always tell patients, I'm going to try so that we never have you notice any loss of your vision. But I go, this relates to things like, I don't want you to trip and fall because you missed a cord that was on the ground that leads you to breaking your hip. And that's like the beginning of the end, right? And they usually can relate to that. Like, okay, like this is important. I don't want it to ever be anything that causes you to have other problems. And I think that resonates with people, especially when it's something that they literally can't see in their day-to-day vision, knowing and understanding you have problems in this area. You need to be careful because of, I think that's a great way to translate to Chris and give that explanation.
Yeah. And I love think that, Gina,
sorry, Shane, I just want to jump in. I love that because there's an art and science in practicing medicine, and the science is looking at the nerdy stuff, right? The art is communicating that to the human that's in front of you and the people that are around them and caring for them, and using the tools that we have, the science, to make it real, to give them those positive advices, suggestions, to help them not only maintain the vision they have, but live their life is incredibly critical. So, Gina, thanks for sharing all of that.
And I think when you have patients with field loss that are still driving and you can show them that field loss, it really becomes easy to educate them about, I need you to have a lot of head movement, right? You can't be looking down the road counting on your peripheral vision. We know that on the left, you're missing this area. You've got to move your head. And I think it helps them visualize that better, maybe.
Absolutely.
And this kind of jumps into what we're talking about here. We all try to do finger counting and all those things. I don't know, maybe 10 years ago, we started running screening fields on everybody. And
ooh, Shane, are we going to get into this?
we are.
Okay, I didn't know we were going to talk about this. I don't, and I disagree. But here, explain it to me. Convince me.
I'll tell you this. I don't care how great you do count fingers, you miss areas, and you do not know what's going on with the patient. And just like we're talking about these early changes that show up, I'm better educated for my patient. I understand the process better, and I have a much more robust test. That leads me to diagnose disease earlier. It leads to more full threshold fields because I know there's this repeatable defect, and I want to know what's there. If I see one square missing on a screening field, am I going to do a full field? No, I say, hey, we're going to repeat your screening field before you leave and see if that's truly there. Back to the more you do fields, the better you are. If you're not doing that, I think you're focused so much on Snellen acuity that you're missing the robustness of what we do.
Are you ready?
I'm ready.
Waiting.
I'm actually waiting for this response.
So I think a couple things, Shane. The first one is that I think you're a unicorn in the sense that you're already doing a ton of fields. You already do a very high level, and you're not afraid to dive deeper when you see something abnormal. My concern with screening fields is we do a screening field, we check the box, and something might look suspicious. And I can tell you already that the data doesn't show that we follow up with what those screening fields show us. So if we're just finding in total, as a profession, we do a screening field and we think, I've charged a patient for this screening field, perhaps we haven't, but we've done it. And now we're uncertain because we've already done the field and we can't answer the question by the screening. And so rather than saying, as you did, Mrs. Smith, I've noticed, and actually I would even go one step further and say, you did the screener once, Shane. Why are you going to make them do a screener again because of that one block, when what you should do is you did the screener, now you need to do a full threshold because you've did the screener to find some defect and you're not certain about it, do the full threshold. And so you've already articulated that it's like one box, I'm just going to repeat the screener. But what I would say is that thought process that goes through most people's minds is they do the screener, they find the one box, and then they either screen, or worse, and you know what I'm going to say, they refer. And they don't really know. Or even worse, they do nothing. And so now they're left with this uncertainty about how to manage it. And that's my biggest challenge with screening fields is the sensitivity and specificity for detecting general, like anything that's going on. When we open that up to a really large audience, as opposed to thinking, I'm doing this field because I know something specific that could be looked at, it leads to a lot more uncertainty as a profession. So I'm not criticizing you for doing it. Because I understand the way you think. I'm criticizing the practice of screening fields in general for all the reasons that I just outlaid. And because yeah.
I would challenge you on, that's not a screening field issue. That's a profession issue. And we should make sure that we practice. As a profession, we're evolving medically, right? Nobody's good or bad, but we're moving that way. And that's the way optometry is going. So we need to challenge ourselves to make sure that we use data. you can document a box that's missed on a screening field and justify it, repeated it wasn't there. You need to follow through with that testing. So I agree with you in the fact that if you're going to do a test, you need to take accountability for that test. I agree 100%. But I also think we don't want to be just vision doctors. We want to be beyond the eye. And if we're going to do that, we need to offer this full robustness of testing.
Let me throw in something real quick, because I'll take a little bit of a different point. I don't think that it's a profession issue. I think it's a system issue. Right? I don't think we have the systems pre-built internally to say, hey, I see something, right? And we've been chatting so much, we've been ignoring the audience, so I apologize, guys. But Ted has, not sure which Ted, I know a handful of you, but appreciate you being on. He likes the word suggestive of, because it doesn't paint him into a corner, and I agree with him. You're not committing to something saying this is this. You're saying, hey, this is suggestive of early glaucoma. This is suggestive of, ocular migraine. This is suggestive of what we see when you're on particular medication. So I love that phraseology, but when you do find that spot, what do you do next? And if you haven't pre-thought that process, then you're either going to ignore or refer, or most likely say, we'll deal with it later because I want to make sure that you buy glasses from me, because that's what my dopamine hit's going to get out of today's visit. But having that process built up ahead of time is huge. I think what test to use as a screener is also a challenge, and where you put it in. Like you guys, we brought in the Radius headset, and mostly because I wanted to have some flexibility. I wanted a good test. And I wanted to make sure every chair in the office could then turn into a visual field chair. And again, I'm working at 1,800 square feet with 2 doctors, so I need flexibility and to move. But I said, guys, I need a better quick screening test, because Shane was able to convince me. I guess I'm a little bit softer than Chris is on doing more screening tests. And they have a 2-zone screener, and they just built a new 16.30-second screener, so it's real quick. And I said, I really like my color, right? Because like Gina brought up earlier, right? I want my red, yellow, green. And so they incorporated the red, yellow, green into that, mostly so that it's not for me, but the patients go, hey, here's some yellow or red. We need to bring you back, right? The test says I need to bring you back. Let's not worry about that today, other than scheduling you that test to come back. But something that quick, and I can throw into the pre-test route, or maybe once I put them, the staff puts them in the chair and waiting for me, they can do a real quick 30-second test, just to make sure that we're good. Because I agree with Shane, the whole finger thing, just I feel like I'm flashing gang signs and I'm not necessarily getting what I need. Gina, do you screen?
No, we do not actively use a screener. And I'll be very frank, right? It's a time constraint, and people aren't good. They're not good at taking these tests without a lot of explanation. And I feel like we would run them sometimes and we would get, false information. But I do run one if I have a suspicion about something that might be significant, to help, especially if I feel a patient is not understanding the importance of what I'm saying, to catch something early and say, hey, we need to have you come back. But I know it is frustrating, right? When you can train people, you can do it yourself, but we've had people that have had retinal detachments where like, I know you shouldn't be seeing anything down here, and yet when I do it, you're saying that you can see it, right? So we know that is a very rudimentary test, but no. And long answer to a short question, I do not regularly do screening.
So I got to jump in, Aaron,
like we got some work.
Yeah, no, Aaron, I think you're right. I mean, I call it a profession problem, but I think it's a systems problem within the profession. And I think you articulated it a lot better. So if you're going to advocate, if you're going to embrace, so what I would say is, okay, Shane, so if somebody were going to embrace, like my reason still is the positive predictive value of running a screening test in patients over the age of 40, if you assume 90% specificity and 90% sensitivity, is exceedingly low to be the diagnoser of glaucoma, right? You're going to run a ton of tests and get a lot of false positives because of that, based on the false positives, sensitivity? I got to go back and look. But the point is that the positive predictive value is going to be really low. But if I'm like, hey, now the optic nerve looks suspicious, maybe it's a 0.65 and a 0.85, and there's a family history, and there's like now all of a sudden, and then I'm going to run my field. Well, now my positive predictive value, if it's because I'm the population of patients who have disease because of those other screening ideas that I'm looking at as the clinician, is narrowing the population down where I'm not going to have to chase rabbit holes. That's kind of the fundamental thing that bothers me. But if I were going to employ a system in my practice so that I wasn't going to give away care because I screened the patient first, what would that look like to you, Shane?
Well, we don't charge for our screening fields. I could tell you that we find enough patients with field defects that generate threshold fields in other disease state that it's definitely a positive economic value in our practice. And in our case, especially with the Radius headsets, we try to move, and I'm in a different scenario. Real estate's cheaper than Pittsburgh, Kansas than it is in San Diego. And so we have a lot of rooms. The more we can move into an exam room, such as a Radius field to do a screening field, the quicker and better we can see patients and make that happen. So I think in our mind, it's just part of the pretest workup. I think one thing that was interesting that you just called out, how much glaucoma are you going to find and treat because of screening fields? But that's narrowing fields of having one disease that they benefit, right? So it's not just glaucoma that you're looking for.
Yeah. I was using that just as an example.
I know, but I just wanted to make sure that everybody understood there's so much more that comes out of it. Aaron, can you bring up that field I sent you?
I will, and as I'm doing this...
But I'm trying to, so you do the screening field, Shane, and then something comes up abnormal. What's your threshold to say, Mrs. Smith, great news, you got a new prescription today. And it's going to make you see clearer. But bad news, unfortunately, I'm noticing that this is the case. And that could be a number of things. Like, what does it sound like? There could be a number of things, and we need to have you back to do a deeper evaluation on what those things are. I mean, what does that sound like to you? And what's the threshold for you to make that decision so you're not just leaving uncertainty and leaving a field that just was like, I don't know what to do with this. I'm trying to get the people to use them more.
Let me see if I can answer. I think I misunderstood your question, but the answer would be, I'm going to look at that, and is there something in their exam or in their documentation that supports the field defect I see? They've had diabetic retinopathy, and there's been macular edema in the past, and there's three areas adjacent to fixation. That's explained by their history. I'm not going to repeat that. I have a reason, and I'm going to document why that field defect is there.
Are you going to add a threshold field based on that in the future? Are you going to now track that?
Probably I will at least get a baseline and make a note. Off the top of my head, the note would likely say, complete baseline threshold field. If there's no further change or incidence of macular edema, or repeat field when there's new macular edema. So I'm establishing a baseline, but I'm not repeating it every year or every quarter. If I see a field defect, there's one box, it's off a little. I'm going to say, Ms. Jones, I want to talk to, somebody mentioned doing our own fields. Hopefully we're delegating, but Ms. Jones, I just want to talk to you about how to do this visual field. I really need you to stay focused for me for just this 30 seconds while we do the screener. You have one area that's a little suspect. I want to see if it's there and it's repeatable. If it is, I'll talk to you a little bit more. If it's not, my staff's going to let you go. They'll bring me the field. I look at it. Great. That one spot is no longer there. It's moved to a different spot. It's testing error. There's nothing reliable. Ms. Jones, I notice here that there's 3 times that we have this spot and there's significant suppression. This is really a robust test. It's like getting your blood pressure checked at Walmart. You're not going to treat based on that. I'm going to bring you back. We're going to do a comprehensive visual field. At that point in time, I want to look for certain patterns that are indicative to disease to us. I want to take time to look at things further. I'm also going to identify the patient's symptoms. Not this field that Aaron has up right now, but I just had a patient that kept saying there's a blurry spot in my eye. I did a screening field. As they came back, there was definitely a spot that showed slight suppression. We scheduled a complete field. There was a spot, and we repeated the threshold field again a week later. There was a spot adjacent to fixation. There was about, I don't remember, about 3-4 decibels of loss right there. And the patient had a complaint that correlated with this field defect that I was seeing. Sent them to ophthalmology. Ophthalmology said, oh, there's nothing going on. We brought them back because we couldn't find anything in their anatomy. Did a third field. That spot was still there. I ordered a CT scan. There was a mass. Then we went to neurology at KU. So what I'm looking for is consistency. I'm looking for a pattern that makes sense and a pattern that's repeatable. If those things exist, we're going to delve into why until we figure out a logical answer for it. We try to do as much of that as we can in office. It's rare that we send it out because it's going to mimic glaucoma, macular degeneration, previous TIAs. There's a robust thing that we can tie their history together and make that happen. But if we get back to a wall and we know this repeatable field defect is there, we're going to continue to work with this patient, their primary care. I think when you think referral, you not being you, Chris, but when we think referral as a profession, we always think ophthalmology, and I think that's something we need to address. Another example I have is a 26-year-old girl that had repeated headaches. Her primary care doctor just kind of, hey, it's probably hormonal, let's see where we're at. We substantiated a field defect. The primary care doctor is now doing a much fuller workup because there's more reason behind what we're doing.
You still just articulated my point to just sort of the threshold field in the beginning. But those are great cases, Shane.
Those are great cases.
Yeah.
Hey, we're getting close on the hour, gang, and those who are joining us running on the treadmill, we're going to go a little bit longer, so you may want to turn the speed down a little bit, just because you're not quite at the finish line yet. But Shane, I want you to hit this case real quick. Gina, I've got a question that I've been burning to ask you too, and then there's one question that we've got from the audience I want to hit before we wrap up.
So to go really quick, this patient had complaints of a spot in their vision. When we were doing they failed a screening field similar to what you're seeing on this. When we were doing their eye exam, they would repeatedly miss a letter. We could repeat this field and get it. This is an easy thing, Chris, I think, for a lot of practitioners to move past to what you were saying and say, hey, there's nothing really going on here. Let's go on. It's a 74-year-old male. Is it testing error? We worked with this patient when we couldn't find an answer that dealt with the ocular anatomy, the visual pathway. We got imaging. Chris, do you have that to bring up as well?
And this just
I do.
This just highlights the importance of this patient had a huge aneurysm that was causing this. This aneurysm was not far from bursting, had to be coiled. Talk about having direct impact on a patient's life. Visual fields, the whole reason I gave Chris this case, I bring it up when I talk. Visual fields, you can't just disregard everything you do.
Chris, I've become secondary to you, buddy.
No, you're primary.
So,
We're interchangeable. That's even better.
Whatever I can see on my screen. I have a field defect. Leave me alone. So,
should have done a screener.
No, I think you should have. I did.
Yes.
But the whole point of this case, and I want to get through it quickly so we don't kill anybody on the treadmill, we need to make sure that we don't pigeonhole visual fields or devalue the information they bring to our clinic. Threshold or screening.
Yep, absolutely. And Shane, you mentioned to me that you look at the visual fields as a poor man's MRI, right? Which for me was a giant light bulb that went off over my head because the amount of data that it gives us, it really that
doesn't deal with just.
No, it doesn't deal with just. I mean, the vision, right? And simple, and not just glaucoma, like where we've pigeonholed it. But it, and I don't know. For me, it turned the test upside down, and really brought home the value of something that was kind of just a check off the box before in glaucoma management. So I appreciated you sharing that.
Yeah, and I think the poor man's, when we look at the visual pathway and the route it takes through the brain and how many areas are impacted and where there can be visual field loss, it is a great opportunity for us to find changes in that anatomy without imaging and check the health and well-being of our patient.
Yep, absolutely. Gina, the test, again, I'm in essence of time. When we, like you, went from a Humphrey test, the big box, we've got a colleague that refers to it as the refrigerator. Now I can't not think of it that way. But we went from that to ultimately the radius. Some of my partners and other doctors felt that we were losing lots of data, right? They were worried about changing from an old unit where the test was consistent to a new unit, even though the printout looks the same. It's arguably being tested on a different unit. So how did you address all the history that you had on patients that you were monitoring that had the data that you needed, the progression analysis, whatnot?
Yeah, so I was moving from an old Humphrey FDT device, and that was really tough for patients. And the first thing I noticed when I switched to the Radius is that people almost always seem to do a little better on their visual field, right? Like I had better reliability. And remember, I have a lot of suspects in my office, right? So that's a lot of the people. And I know we were talking about the importance of visual field testing for all types and different, kinds of potential diagnoses and conditions. But when you think about it and you're watching these people for any possible subtle, repeatable change, if all of a sudden there was a suspicious area and I switched over, I had noticed people seem to be doing a little bit better. Like there was some excellent repeatability, but maybe that defect wasn't as deep. And maybe all of a sudden I'm getting better reliability. And I really tied that back to the ease and comfort of using the Radius headset, because many of my patients, and we mentioned this earlier, had postural issues, right? It was literally just so physically fatiguing for them to be in that instrument for so long that it affected their outcome, right? And their score. So that was a really big benefit. And I think, for those of you who are listening to this podcast and you listen to people like Shane talk about, he's obviously so knowledgeable in his visual fields and what he's talking about. I don't want people to be intimidated because it really isn't hard. And I really like to focus on the patterns to get to your answer, Aaron. I would look at trends and data, and I would have taken fairly reliable notes. And I always think to myself, what would have happened if that instrument died and I didn't have any information to rely on and I needed to rely on my chart notes, right? My chart notes should be good enough for me to understand what it was I was seeing and what I was watching. And that's kind of how I thought of this transition into the Radius. And it's been very, very smooth. It's been seamless for us. Most everybody likes testing on this technology much better than the old technology. And I'm having good, reliable results most of the time.
Yep. Perfect. Shane, Chris, have you guys seen anything? Have you addressed it differently? Because I've done exactly what Gina said. I really just took the last one as a jumping off and started measuring and started doing more of them based upon the discussions that we've had previously, to where I didn't really feel like I was losing anything.
Well, I think if you look at the printout that the Radius gives you, Aaron, it's almost exactly the same as what we're used to seeing from all of our traditional testing. And so at some point when you get new devices, you're gonna have to refer back to your old devices. Just imagine imagine the Polaroid pictures. When I came into practice, my dad still had pictures in a physical chart of Polaroids from his, from the optic nerves for patients. Yeah. And so we have to evolve some way. And so I think there just has to be a line of where you're going to stop and then move forward. And probably the best thing is that when it looks similar to what you're looking at, what you're used to looking at, it just makes the transition easy.
Yep, absolutely.
And I think when we were looking at virtual headsets, one thing that really attracted us to the Radius is the stimulus very closely mimics the Humphrey versus some other devices we see. So we can feel very confident no matter what the disease state is, we're getting very similar results because the Radius technology is there. We're also using a software now that allows us to upload fields. It works with Radius and several other systems where you can flicker through fields. And Gina, to your point, looking at patterns a lot, and when you can scroll through 8 or 9 fields and really start to see that subtle change in pattern, it becomes very simple to notice progression.
So that makes I think it's a lot of worry over nothing, right? When we're progressing. By the way, if anybody wants an old Polaroid, I think I still have that camera in storage, and I don't know how to use it. Dad might be for hire to teach you how to do that, but I think it's there. Real quick, Shane, we started at the because now we're killing the treadmill guys, but when we talked about how you read the test, you brought up mean deviation. I want to just end because we did get this question, and I appreciate it being honest and saying, hey, just remind me what a mean deviation is, remind me what a pattern standard deviation is, and when the scores there are significant. So we don't have time to dive super deep into it, but the elevator version of what those are.
So real quick, mean deviation, how much is the field changed from what we consider a normal? -2 is a point you should start paying attention, and then watching progression as that moves forward. Pattern deviation, the higher the number, that's good. That's how far away, how many standard deviations it is away. The higher the number, the more advanced disease or the worse field you have. That's a very quick way to think of it. Gina, how would you?
Oh, that's awesome. I love that explanation. No, I have nothing more to add to that. That was great.
Yep. Shane, I got a ton of respect for you, man, and I've given you a lot of hard time on this podcast, and historically. So thanks for letting me do that. Maybe one other point I would add to it is thinking about the mean deviation generally as the entire field, sort of like as a general sense of how the patient can see in total, and then the pattern standard deviation is locally within that total. If you kind of reduce the whole threshold, reduce the whole amount by the same, where are those areas that are more localized? That's kind of how I think about the difference between the two. It's not as good as the way Shane explained it, but it helps me in my mind.
And that's how I explain to total deviation versus pattern, because sometimes patients who might have like a dense cataract, they see the total deviation and they get worried, right? They're like, why is that so different? And it's not always different, but why is that different sometimes from the pattern? That, what you just said, Chris, is a nice way to explain it too.
Cool. Well, I appreciate everybody for sticking with us beyond that hour. Gina and Shane, I absolutely appreciate you guys making time to share your knowledge and expertise. It's when you've got folks like these who really know their material, who are heavily involved in research, but understand what we do because they own their own practices. They're seeing patients. They're doing this on a day in and day out. They're responsible for the well-being and health not only of their patients, but of their practice and their teams within the practice. Right? You guys wear a lot of hats, and you're both big mentors of mine. So I appreciate you guys making time to join Chris and I on here.
Thanks for having us on.
Yeah, thanks a lot, guys.
Thanks, guys. Appreciate it.
So hopefully we can do this again in the future, because I've enjoyed the discussion, and I've taken a lot of notes and learned some. So with that, thank you, everybody. Thanks, everybody, for joining us, and we'll see you next time.
Hey, if you enjoyed this episode, make sure to subscribe to us on Apple Podcasts and our YouTube channel, both linked in the show notes. Now, here's something exciting. We're giving away a 1-year subscription to Comprehensive Optometry Simplified. All you have to do is leave us a review on Apple Podcasts, take a screenshot, and email it to me at questions@icodeeducation.com. We'll put that in the show notes as well. We'll be selecting a winner on December 15th, so don't miss your chance to get access to this valuable resource. Thanks again for listening. I can't wait to see your reviews.